All right. I think we're going to go ahead and get started. Um, hello, everybody. Thank you for participating in today's webinar on the ABCs of Pompe disease. Today's guest speaker is Erin Huggins, who I'm sure many of you know. Erin is a board-certified genetic counselor in Durham, North Carolina. She received her BS in biology from Coastal Carolina University in 2016 and her master's in genetic counseling from the University of South Carolina in 2018. From 2019 to 2024, Erin was a member of Dr. Priya Kishnani's Pompe disease clinical and research team at Duke University, where she participated in numerous research activities related to lysosomal and glycogen storage diseases, with her primary interests in newborn screening for Pompe and clinical variation interpretation. In addition to her research role, Erin provided clinical genetic counseling for patients across the lifespan with a variety of inherited metabolic disorders. In 2024, Erin stepped down from her role on Dr. Kishnani's team to pursue her PhD in molecular genetics and microbiology at Duke University, where she continues to contribute to research related to Pompe. Thank you so much for joining us, Erin, and for giving this talk. Throughout the presentation, if you have any questions, you can send them at any time by clicking the Q&A feature at the bottom of the Zoom window. We will be answering the questions at the end of the presentation. Thank you so much. And with that, I will turn it over to Erin.
Thank you so much, Tiffany, for that wonderful introduction. I've got my slides up. If somebody could just give me a thumbs up that you guys can see the correct view. Awesome. Okay, great. Well, hi, everybody. My name is Erin Huggins, and as Tiffany mentioned, I'm a genetic counselor at Duke University, and I'm really excited to present to you today the ABCs of Pompe disease, which I'm sure you read the overview, but it's essentially just a talk to go over some of those medical jargon, some of the definitions of Pompe, some of the very most basic topics of discussion surrounding Pompe disease. Hope everybody's having a wonderful new year so far. And with that, we will go ahead and get started. All right, Tiffany just gave a wonderful introduction, so I will be brief, but just a little bit of background on me. I'm a genetic counselor. I received my degree from University of South Carolina back in 2018. I promptly joined the Duke Children's Department of Pediatrics Division of Medical Genetics team. I've worked alongside Dr. Kishnani for the last 5 years or so. If any of you have ever come to see Dr. Kishnani in clinic within the last few years, there's a very good chance we have interacted. But recently I've shifted my roles just a little bit. I'm still here at Duke, but I've actually returned to graduate school to the Molecular Genetics and Microbiology program here at Duke to pursue my PhD. And I am still very much active in Pompe disease research. So it's a pleasure to be back. Here's a few topics of discussion we'll go through today. We'll first review a brief history of Pompe disease, just because I'm a pretty big history nerd. We'll go over the very basic definition. What is Pompe disease? We'll talk about genetics and inheritance, a little bit about newborn screening, disease management, and then we'll end with a Q&A. You're welcome to put your questions in the Q&A box during the presentation. I probably won't get to everything until the end, but please feel free to put your question in the box whenever one comes up. All right, so let's start with a very brief history lesson. So where did the term Pompe come from? Who is Dr. Pompe? So this condition was actually first described in 1932 by a Dutch pathologist named Dr. Johannes Pompe, or if you're Dutch or European, you might hear it pronounced Dr. Pompe. And he first reported an autopsy on a 7-month-old who had died of respiratory failure. Had noticed this really interesting glycogen accumulation in the muscle tissue, especially in the heart in this infant. And so this is the first described case of what now became Pompe disease. In the 1950s, it was further characterized by a scientist, Christian de Duve, who observed that a deficiency of a specific enzyme known as GAA, which we're going to explain what that is in the next couple of slides, that this specific enzyme missing could explain the symptoms of Pompe disease. And so with that, Pompe was the first ever lysosomal storage disease described. Pompe is known by many other names. You might hear it called glycogen storage disease type 2 or GSD2, the acid maltase deficiency or AMD, which I think we're all very familiar with that term here, acid alpha glucosidase or GAA deficiency, or even glycogenosis. So most of these terms aren't used that frequently anymore, but if you see them, they all are referring to the same thing, Pompe disease. So what is Pompe? Let's go over a definition. If someone were to come up to me and ask me, Erin, what is Pompe disease? This is what I would tell them. It's an inherited metabolic disorder that impacts the body's ability to break down the substance glycogen for energy. Now, I realize there's a lot of words in here that aren't part of our day-to-day vocabulary, so I tried to pick out what those words are and break them down for you. So the first one is inherited. What does that mean? Inherited and genetic are often used interchangeably, and it just means something that's passed down through family, something inherited. So not something acquired, not something you caught from somebody else or something that just spontaneously happened during pregnancy or during development. It is passed down, and we'll talk about that later in the presentation. Metabolic or metabolism, a lot of people hear that term and they think about like weight gain or weight loss, but metabolism is actually a much broader definition than that. And it refers to the breakdown and buildup of all products in the body. And finally, glycogen. So glycogen is simply a stored form of glucose or sugar that is kept up in the body and broken down for energy use whenever energy is needed. So with that information, we can classify Pompe disease as both a glycogen storage disorder and a lysosomal storage disorder. So a GSD or an LSD. And so we'll talk a little bit more about what each of those means. So first, I like to give a little metabolism of glycogen lesson. So let's think about this in terms of it's lunchtime. I know we're got a bunch of different time zones here, so I just had lunch about an hour ago. So that's where I get my energy from. So there's lots and lots of different molecules in here. Glucose is just one of them. It's a carbohydrate, simple sugar, but that is what the body likes to use for energy. So I obtain this through the meal that I eat. So I'm going to use this glucose to make energy to carry out my day-to-day functions. I'm using up energy right now to give you this presentation, to go for a walk later, to just exist. So I think of these Lego pieces, they're individual bits of glucose. So let's say I ate a pretty big lunch, I'm very full, I use up all the energy I need right away, but there's still some left over. That extra glucose gets stored in a much more complex molecule called glycogen. So here is if we built a Lego, structure, and it's a little bit more complex, and that's kind of how glycogen forms in the body, and it stays in our cells. So a few hours pass, it's 4 p.m. the end of the day. I'm probably not going to eat dinner until like 5 or 6, but I'm feeling kind of tired. I need some energy. The body's going to break down that glycogen back into glucose for me to use for energy. And so that is a normal reaction in the body. This happens in every single person. And so what we're going to be focusing on is that breakdown. Let me see if I can get a pointer. I can't figure out how to use the laser. Anyway, but what we're going to focus on, I don't know if you can see my clicker, is this breakdown of glycogen back into glucose. So glycogen is metabolized or put together and broken down in 2 major places in the body, the liver and the muscles. And so thinking about your liver, that's a pretty big organ. It's responsible for a lot of maintenance and upkeep of your body. So think about just your everyday functions, your heartbeat, your breathing, your organ function, keeping you alive, basically. A lot of metabolism is going down in the liver, so a lot of energy is needed there. Your muscles are also a really big user of energy in the body. So what do we use our muscles for? Just about everything, sitting and standing, walking, talking, running, lifting. Your muscles are a really big user of energy, and they're also a big user of glycogen. So let's zoom in a little bit to a muscle cell. So remember, let's go back to high school biology for a little while. Cells are the most basic units of our body. So we're made up of trillions of cells, but cells are unique to different tissues. So you can have skin cells, liver cells, muscle cells, so on. And these cells all have very unique and important functions to carry out. So up here in this top, we have a picture of a cell. Lots and lots of different little compartments. Don't worry about all of that. What we're focused on right here is the lysosome, this little blue circle here. So lysosomes are they're small compartments in the cell where a lot of those metabolic reactions are happening. So the breakdown and buildup of products. Some people refer to them as the recycling center of the cell, or processing center, however you want to think about it. And so you can imagine this is a pretty important part of the cell. All of this processing and breakdown is done by special molecules that are called enzymes. And the specific enzyme that's affected in Pompe disease is called GAA, or acid alpha glucosidase. And so GAA enzyme is responsible for that breakdown of glycogen in the lysosome. Oops. All right, so what's actually happening to cause Pompe disease? So here's our lysosome. Let's look at it this way. Here's our lysosome, and inside are these glycogen molecules. So we've properly made the glycogen, so we're storing that for energy. But whenever the body's ready to break it down into glucose, the GAA enzyme comes in and breaks this down further to smaller bits, or essentially glucose used for energy. Whenever there's not enough GAA working to do the job, so let's say we have a deficiency of the GAA enzyme, we wind up with this buildup of glycogen molecules. And so as you can see, they're getting bigger and bigger. They're stretching out that lysosome. It's eventually going to rupture and cause cell damage. So this damage is happening, like I said, mostly in the muscle cells, and that's what causes the symptoms of Pompe disease. So a quick recap of everything we have gone over so far. So Pompe disease, or Pompe disease, is named after a Dutch pathologist who first described it in 1932. It's caused by a lack of an enzyme known as GAA that's needed to break down the substance glycogen for energy. The lack of GAA causes glycogen to build up and ultimately causes damage to the body's muscle cells. And this cell damage is what leads to the symptoms of Pompe disease. So that brings me to our next topic. What are the symptoms of Pompe disease? So we know that the amount of GAA that's produced impacts the type of Pompe disease a person has. So what does that mean? Somebody with very, very little to no GAA enzyme, so 0 to about 1%, is going to be classified as having infantile onset, or IOPD. And so with very, very little to no GAA, you can imagine that buildup that we saw on the previous slide, that happens really, really quickly. And thus that cell damage, that cell death is happening a lot faster. And so that's why the onset is as early as it is, within the first few days to weeks of life, sometimes as early as in utero. Individuals with IOPD can be classified as CRIM positive, meaning their body makes a very tiny amount of GAA, or CRIM negative, meaning their body makes no GAA enzyme. Late onset Pompe disease, or LOPD, the body does make some GAA. It is reduced. It's not enough for normal function. It can be anywhere from 1 to about 30%. And this causes a slower onset, progressive onset of disease. And late onset isn't always the best term, I feel, these days, because late kind of gives the impression that it's later in life, and that's not necessarily true. We do know that individuals with LOPD can present as early as the first, few months of life. And so by nature, because they are producing some GAA enzyme, everyone with LOPD is considered CRIM positive. So let's look at some of the characteristics of IOPD. I'm sure most people on this call are familiar, but I just like to highlight those real quick. So what's characteristic about IOPD is hypertrophic cardiomyopathy, or basically what that just means is an enlarged heart. So remember those lysosomes I showed you that fill and fill and fill with glycogen? That's essentially what's happening to the cells of the heart. So that heart is made out of muscle. Those muscle cells get damaged really, really fast. And so we see this enlargement of the heart that can lead to difficulty breathing, heart rhythm problems. So it's not just the heart, it's all of the muscles in the body. So we see this very rapidly progressive muscle weakness. A lot of babies with IOPD have delayed milestones. They don't really sit up or crawl. They have this floppy baby kind of appearance. Um, and because the symptoms progress so quickly, there are poor outcomes if untreated. Treated patients do really well. They may have persistent muscle weakness, hearing loss, and speech differences, and other medical challenges, but otherwise, the spectrum is so vast that it's kind of hard to fit all into one line here. Um, for LOPD, the onset can happen at any point in the lifespan. You'll encounter lots of adults with LOPD that might not have been diagnosed until their 50s or 60s, but may have had symptoms much earlier in life that went unnoticed or were very mild, but progressed and got worse over time. The characteristic difference is there's no cardiomyopathy, there's no cardiac enlargement within the first year of life. That's really what distinguishes these two. It can present as early as the first year all the way into adulthood and involves much more slowly progressive muscle weakness and respiratory compromise. Children with LOPD can have developmental delays, difficulty climbing stairs. Adolescents, adults can have trouble playing sports, sometimes breathing difficulties. It varies significantly. But this is a brief summary of some of the symptoms we can see with Pompe disease. One thing I want to point out is we're not able to predict disease severity or disease course based on the amount of measured GAA activity in the body. So GAA is something we most often test for in blood. And you might be saying, well, Erin, you just told me that, 0% to 1% is IOPD and greater than that is LOPD. So we can predict that based on a combination of the GAA and the genetic variants, which we'll get to, but we're not necessarily able to tell a difference between like a severe LOPD or a milder LOPD just based on the GAA. So I couldn't tell you if somebody with 15% activity versus 10% activity is going to do differently, because those values do fluctuate a little bit over time, just what time of day it was collected, how old the person is. So someone with Pompe disease is always going to have low GAA enzyme. So I could check anybody's enzyme at any point in time and it will be low. But that number is not, I'm not going to be able to predict the disease severity based just on that. So hopefully that makes sense. The type of Pompe disease also does not change over time. So an adult with infantile Pompe disease will still have infantile Pompe disease. It won't change. It's referring to the onset of the symptoms, not necessarily the age the person is at the time. All right, so let's move into the genetics and inheritance of Pompe disease. As a genetic counselor, a topic, of course, very near to my heart. So let's go back to our cell for a little while. So we talked about the lysosome and what's so important about those. But there's another really important part of the cell called the nucleus, which is kind of the home base for the cell. And inside the nucleus contains all of our DNA. And so I think about DNA as the instruction manual that's unique to each of us. That instruction manual tells our bodies how to look, how to grow, how to develop. So think about buying a piece of furniture from, let's say, IKEA. They usually come with instruction manuals. So ideally, you'll read the manual, you'll put the piece together. I know that's not always the case, but let's say that it is. All right. If you have some kind of error in that instruction manual or a mutation, so in this case, it's a little bit hard to see. Those first two lines here, they're gone. There's a mutation. All that's left is this one little line of text here. And we follow it and we put together some crazy looking piece of furniture, right? We're not able to properly carry out those instructions. That is essentially what a mutation does to a gene. It makes it to where it can't produce a normal product. So in the context of Pompe disease, Let's think about our DNA all made up of individual genes, which we inherit from our parents. We get one copy from mom, one copy from dad. Each gene in the body has some special job to do. So think about it as there's a gene that helps make 10 fingers and 10 toes, and there's a gene that helps make brown hair, and there's a gene that makes the GAA enzyme. It's called the GAA gene, which is really helpful to remember. So that's its entire job. It makes this enzyme that we know is responsible for breaking down that glycogen. So if there's an error in the GAA enzyme instruction manual, the body can't properly make GAA enzyme. It might not make any at all. It might make GAA enzyme, but it's a little bit abnormal, kind of like this couch here, that it just doesn't work quite right. And ultimately, that's what leads to the symptoms of Pompe disease. So as a reminder, we've got 2 copies of each gene, and the gene we're talking about here is GAA. There's many different types of genetic mutations or changes that can happen in that gene. So I'm not going to get too much into how DNA is read in the body, but essentially it's read in groups of 3. So 3 letters. So we have the, cat, sat. So that's a sentence we can all understand. Each word's made up of 3 letters. So one type of genetic change is called a missense change, where just one letter is changed. So in this case, we have the car sat, which those are 3 words that we all recognize, but now the sentence just doesn't really make a whole lot of sense. So that would be considered a mutation. You have something called a nonsense mutation, where all we have is a T and then it stops. Then the rest of that DNA is not getting read. You're not really making a complete sentence at all, actually. So your body's not going to be able to read this and tell you what it means. You can have a funky mutation called a frame shift, where we have a deletion of the letter H. And remember, the DNA is read in groups of 3, so that kind of shifts everything over. So with this deletion, we have, it looks like some remnants of the cat sat, but because we don't have 3 variants here, this stops being made. We can't really read what this says. We can have a deletion where in this case, the word cat is deleted and we just have the sat. And again, that doesn't really make a whole lot of sense. These are just some examples of types of mutations that can happen in the body. There's a lot more than this. These are the most common ones we see in Pompe disease, are just, examples of those. But what's most important aren't the individual mutations themselves, it's the combination of variants. So remember, we've got 2 copies of every gene. So the combination or the genotype, that's what predicts whether someone has IOPD or LOPD and how much enzyme the body can actually make. So for example, if you have 2 nonsense mutations, so remember nonsense, that's that second one on the list here, the body is just not really making any protein at all. If you have 2 of those in combination, that's most likely going to result in IOPD. Your body's not making any enzyme at all. However, if you have something like a missense mutation, which does make an actual sentence, it's just not really making a whole lot of sense, plus something like this is a very common variant we see in LOPD that we know it results in some normal enzyme activity. Someone like that is going to make some GAA enzyme, they're probably going to have LOPD. So these are just examples. This is not all-encompassing. There's thousands of variant combinations. So I always say you should always talk to your doctor, your child's doctor, geneticist, or genetic counselor to help understand what your specific or your child's specific combination of variants may mean. Because most of the time when you're getting a genetic test report, you're not going to be able to tell a whole lot just from that report. So again, these are just examples of what could happen. Another point I like to make is some people refer to certain variants as this is an infantile variant or this is a late onset variant. And I always encourage people to think about it not as one or the other, but in the context of a combination. So when in combination with something else, what does this result in? And so that's going to be different for everybody. So that's why I always recommend talking to your doctor, genetic counselor, to really get a good understanding of what those mean. So how is Pompe disease passed down through families? We did say that it's genetic or inherited. And so this is an autosomal recessive condition. So what do those terms mean? So autosomal just means something that is on the autosomes or the chromosomes that everybody has. So this affects any gender, male, female, does not matter. Recessive means that it requires two genetic variants or two mutations. And the way that usually happens is one mutation from each parent to actually cause the disease. So this is in contrast to a condition that's autosomal dominant, where you only need one mutation to cause the disease. In this case, you need two. So what happens when two carrier parents have children? So hopefully you guys can see this graphic pretty well. So we have dad as a carrier. So he's got the check marks represent, let's say, a normal working copy of the gene, and an X represents a mutation. So you can see each parent has one normal working copy and one mutation. So neither of these parents have Pompe disease. Neither of these parents have the condition. But with every single pregnancy, there's a 1 in 4 chance, or a 25% chance, to have a child with two variants. So that in this case, this child has inherited both mutations from the parent. There's a 50% chance that each child will inherit just one mutation from one parent, so mom or dad, and a normal copy from the other parent. And that's why there's two possibilities, right? Because either dad could pass on the mutation or mom could pass on the mutation. There's another 25% chance that each child inherits both normal working copies and thus does not have the disease and cannot pass it on to their future children. An important note about carriers. So carriers of Pompe disease don't actually have the condition themselves. So a couple of reasons somebody might be concerned about this. This is rare, but it does happen. In some cases, a parent of a child with Pompe disease goes to get carrier testing and finds out that they actually have late onset Pompe disease themselves. Like I said, it's not common, but it certainly can happen. And there's also individuals that say, well, hey, I found out my child has this condition and I have some fatigue and muscle weakness and breathing problems myself. And to those individuals, I always say, talk to your doctor. Let's confirm you are truly a carrier. And we can determine that by looking at your genetic mutations and your GAA enzyme. So if that GAA enzyme winds up being in the normal range, we know that it's not Pompe disease. We say, let's try and find another cause for these symptoms. Alrighty, so we're going to go through a couple of different scenarios here of an individual with Pompe disease and what it looks like for passing it on to their future children. So individuals with Pompe disease can have healthy children without the condition themselves. This depends on the carrier status of their partner. So we have, in this case, an individual with, let's say this is Pompe disease, this is two mutations, and then we have their partner who is not a carrier, has two normal working copies. Then each of their children, 100% chance, will be carriers of Pompe disease. They'll inherit one normal working copy from, let's say, mom, and they'll inherit one mutation from, let's say, dad in this case. And this is what all of their children are going to look like. So this individual cannot have a child with Pompe disease if their partner is not a carrier or is not affected. If someone with Pompe disease has a child with someone who's a carrier, so not affected, but just has one mutation, hopefully you guys can see my clicker there, then there's two things that can happen. One possibility, or 50% chance, that one parent passes on their normal copy, the other parent passes down a mutation, or both parents pass down a mutation. So there's a 50% chance for them to be affected. And depending on which mutation it is, this could be a case of an LOPD, a person with LOPD actually having a child with IOPD, depending on which mutation gets passed down or which mutation their partner has. So it's really important to know this information ahead of time if you're planning on having children. The other possibility is if two people that both have Pompe disease decide to have a child together, then every single one of their children will also have Pompe disease. Because the mutations will combine in different ways, again, this could result in a different type of Pompe disease than what the parent has. So it's really important, again, to know what those specific gene mutations are to understand your chance of passing them down to a child and what condition, if any, that child could go on to develop. I have a quick slide here on something called a pseudodeficiency variant or pseudodeficiency alleles. I don't want to get too much into this, but it's a topic that comes up a lot, and you might be thinking, what in the world does this mean? So this is not something that's unique to Pompe disease. It actually happens in a lot of genetic conditions. It's this phenomenon known as a pseudodeficiency. So the word pseudo just means false. So in this case, it's a falsely low GAA enzyme that's on a blood test. But this is not actually representative of low GAA in the body and does not actually cause Pompe disease. There is a couple of known pseudodeficiency variants in Pompe. There's a couple that are very known, very common in Asia, but these can be seen in all ethnicities. So a lot of people have no pseudodeficiencies at all. Some people have one, some people have up to four, depending on their parents' genotypes. Sometimes these pseudodeficiency variants are seen alone, but sometimes they're seen alongside actual disease-causing variants. So you should know that if you have a pseudodeficiency, that doesn't mean you can, or that doesn't mean you can't have Pompe disease. So here's a couple of examples. So if you have, let's say here we go, one pathogenic variant, one mutation, and one pseudodeficiency, that person's enzyme might show up low on a blood test, but then we do DNA testing to see what are the actual mutations. We see that this person is actually just a carrier. Let's say we test someone else and there are two mutations and a pseudodeficiency, then we would presume that person is affected. If there's somebody with just two pseudodeficiency variants, but no other mutations, everything else looks normal, even if that enzyme is low, we would say that individual is not affected with Pompe disease and is not a carrier. If it's just somebody that has just one pseudodeficiency variant, again, not affected, not a carrier, no chance of passing this on to future children. So to summarize, this is just a falsely lowered GAA enzyme activity. That's why it's really important part of testing that we do both GAA enzyme testing in blood and DNA testing to look at the mutations. All right. Quick recap before we move on. So as a reminder, Pompe disease is caused by a lack of GAA enzyme, which is responsible for breaking down glycogen in the muscles. People with IOPD have very little to no GAA enzyme. Cell damage happens fast. The onset and progression is very fast. People with LOPD have some GAA enzyme, but not enough to work normally, and cell damage happens a little bit more slowly over time, but can still present at any point in the lifespan. The impact on the GAA enzyme is determined by a person's GAA gene mutations. Some mutations are more severe than others, but the combination of mutation is what is important for predicting what type of Pompe disease someone has. Another quick note on that is just because two people have the same mutations, the same two gene mutations, does not mean they're going to have the same exact disease course or the same symptom onset. So if you think how much variation exists naturally just between two people, not knowing their disease status at all, GAA is just one of over 20,000 genes that humans have. So those two mutations are not going to be what dictate alone, are not going to be what dictates the disease course for somebody. It's going to have a lot to do with many, many other factors. So just know that if you have a certain combination or you know somebody with this, a certain combination, you two may not look the same, or your children may not look the same or have the same disease progression, because there are so many other factors aside from mutations that can impact that. Pompe disease is an autosomal recessive condition, meaning it's passed down from two carrier parents. It is normal to have no family history of Pompe disease. I encounter a lot of people that say, how could this be? There's no family history. And that's like the most normal scenario, because since it takes two parents who are both carriers to have a 1 in 4 chance of having a child with the condition, each of those parents probably came from many, many generations where there was nobody else that they had a child with that was also a carrier until they happened to come together. So having no family history does not rule out the possibility of having Pompe disease. So confirmed carriers who have a normal GAA enzyme and only one mutation don't have Pompe disease themselves. However, some parents who have only, maybe they only had targeted testing just for the mutation that's in their child, and they want to know with 100% certainty that they don't have Pompe disease, they can get additional testing to do that GAA enzyme and do full gene sequencing if they want to rule out the condition for themselves if they have symptoms, or determine, do I need to seek out other medical care for these symptoms? And finally, individuals with Pompe disease absolutely can have children of their own, and they can have children of their own with or without Pompe disease, depending on the carrier status of their partner. All right. I see a lot of questions coming up in the chat, so keep those coming. So moving on past genetics into a little bit of newborn screening. So again, most of my time at Duke was spent studying the outcomes of individuals with LOPD diagnosed via newborn screening. It's probably how I ended up interacting with a lot of you on here. So this is going to be a pretty brief overview since that's not like the main focus of our talk today, but always happy to talk about that offline. So Pompe disease was added to the Recommended Uniform Screening Panel, or the RUSP, in 2015 in the United States. And what that means is every single state in the US has a certain list of conditions they test for in all babies who are born in hospitals. This is a federal program. It's no charge to the families. It gets done probably without you even knowing it to your baby. But there's this list called the RUSP that people can nominate conditions to. Say, I think we should start testing for this at birth. And it's very, very hard to get a condition on the RUSP. It's not something any person can just call up and say, hey, I think I want you to screen for this condition. It took a lot of work to get Pompe disease added by many, many groups of people, including our group here at Duke. And so it made it onto the RUSP in 2015, but that didn't mean we automatically started screening for it. So one by one, each state ultimately added Pompe disease to their newborn screen panels. To kind of put in perspective the growth, when I started at Duke in 2019, I believe 28 states were screening, and now here in 2025, you can see this map is almost filled up, which is totally awesome. It's been really exciting to see. Even my own state, just a shout out to North Carolina, we started screening in February of 2023. So not that long ago, actually. So it's just really been a joy to watch these states adopt newborn screening and to meet families from every single state that's reached out to our team. So if you live in one of these states that's not highlighted, give me a shout. Maybe there's maybe there are organizations in your state trying to add Pompe disease to your screening panel. It's possible that there's a work in progress happening in these other states. So like I said, most people don't even know that newborn screen is happening to their baby unless they get a phone call a few days afterwards. So here's just a quick overview of, what's actually happening before you get that phone call. So once baby is in the nursery, a tiny sample of blood is collected. It's called a blood spot. You can see that on the far left here. What happens is the nurse will take a very small needle and prick the end of baby's heel and collect a few blood samples. This is usually done within a day or two of birth. It depends if baby's in the NICU or there's some other birth complications. It might not happen right away, or it might need to be repeated. This is pretty standard. They take that card and they ship it to, there's a special lab within your state, usually called a public health lab or newborn screening lab, where they analyze these samples. And they're testing for 30, 40 different conditions. It varies a little bit by state. So of course, in this case, we're talking about Pompe disease. And so what they're looking for is GAA enzyme. And so if that GAA enzyme is low, the newborn screening lab is going to pick up the phone and call your child's pediatrician and say, hey, we have this abnormal newborn screen. For Pompe disease, we recommend you bring the family, the baby back in and do some confirmatory testing. Okay, because newborn screening, it's just a screen, not a diagnosis. So I think of it as a screen is meant to pick up everyone and miss no one, right? Because the inverse of that wouldn't be so great. If we were really selective, we'd have a higher chance of actually missing people with Pompe disease. Whereas in this case, we have a higher chance of picking up people who don't actually have it. So once that phone call is made, the family is contacted. We say, please bring your baby in. We're going to do some additional testing. And that might be a confirmatory GAA enzyme. We're definitely going to do genetic testing to look at those mutations. We're also going to look for things like enlarged heart or breathing problems that can be early signs of IOPD. So like I said, newborn screening is pretty broad. Ideally, it can detect both IOPD and LOPD, but sometimes it picks up carriers and false positives. It probably will also pick up pseudodeficiencies. That's happened a lot here in North Carolina. And so that's why that follow-up testing is really important to come in and clarify what exactly, are we dealing with here. So newborn screening is really important because early intervention makes a big difference in clinical outcomes. So I'm not getting into this today, but I believe there's another talk that's on the AMDA YouTube from myself and Dr. Kishnani on what those outcomes of newborn screening actually are. So with infantile Pompe IOPD, we know that the earliest possible intervention with enzyme replacement therapy leads to the best possible outcomes. And with LOPD, that lets us know, hey, we need to closely keep an eye on this kiddo. Let's check for developmental milestones, muscle strength, and monitor them over time so that if and when symptoms do show up in childhood, we know when to act and what to do about it. So once a diagnosis is made, once we do all the confirmatory testing and we say, yes, this baby has Pompe disease. So one thing that could happen, of course, is that they don't have it. They are a carrier, have a pseudodeficiency. We confirm them. We confirm that with additional testing. We discharge that family. Ideally, somebody will provide a little bit of genetic counseling, what that means for future pregnancies. But that baby does not have Pompe disease. They hopefully never have to hear from us again. If we confirm a case of true IOPD, then we immediately start enzyme replacement therapy, which is the only treatment that's available for Pompe disease, where we essentially supplement the missing enzyme, the GAA enzyme. Of course, many of you know there's a lot of clinical monitoring that goes on. So we're getting them to see cardiology, physical therapy, doing biomarker testing, just all hands on deck to make sure this baby gets everything they need and gets established with providers as soon as they can. If we confirm that a child has LOPD, and remember, this is based on both the GAA enzyme and the gene mutations, we don't start any intervention right away. Most children with LOPD that it's confirmed at birth generally look pretty healthy. Like I said, they don't have the cardiomyopathy, they don't really have breathing problems, but we're still going to keep a really close eye on them. And we recommend close clinical monitoring. If you've been through our clinic here at Duke, you're very familiar with all of the testing that's done during a clinic visit. With the most important of those being physical therapy. So we're doing tests to see is this baby kiddo developing properly, hitting their milestones, how's their muscle strength. We're checking their biomarkers. Is there anything that's abnormal that we should be following up on? And ultimately, if and when they do become symptomatic for Pompe disease, which that's going to look different in every single child, at that point, then treatment intervention will start either or enzyme replacement therapy, physical therapy. So the kind of bottom line here is that it's kind of look different for every single child. This is very much a generalization. This might not be how it happened for you. There might be a few steps in between. There might be kind of an unusual combination of mutations where we say, I'm not sure if this is IOPD or if it's LOPD. I don't know. Newborn screening is kind of changing the landscape of how we interpret this information. And how we actually intervene for these children to give them the best possible outcomes. So it's possible that this changes over time, but this is kind of how the standard is right now. And finally, I want to talk about disease management. So I'll be brief on this since we're just kind of going through the basics here. So there's no cure, we know, for Pompe disease, and that's true for most genetic diseases. But there is treatment available, and that is through intravenous enzyme replacement therapy, or ERT, which is exactly what it sounds like. We replace the enzyme that's missing in somebody with Pompe disease, so GAA. The earlier, the better treatment for IOPD. We see better clinical outcomes. Whether somebody is CRIM positive or CRIM negative might depend, again, that CRIM being if there's any if there's any residual GAA enzyme. So depending on CRIM status, some children might undergo like an immune tolerance induction at the time of ERT initiation, which is where we suppress the immune system to reduce the likelihood that the body is going to react to this medication. For LOPD, ERT is dependent on the timing of diagnosis or symptom onset and severity. So in the case of newborn screening, where we've got a pretty healthy baby, we probably won't start ERT right away. But if someone is diagnosed in their 50s or 60s, they've had a 10-year-long diagnostic odyssey of progressive muscle weakness, respiratory problems, they're clearly very symptomatic, ERT might start right away for that person. I've got a couple of the medication names down here. Again, it feels like alphabet soup sometimes, but this is currently what's approved for Pompe disease. And this was actually last updated earlier this or 2024 now. So I try and keep this table up to date. Of course, there's clinical trials going on for all of these different medications in different age groups and other ones that aren't listed. These are just the FDA approved ones in the United States, I should also mention. So this might be different in your country. And finally, I want to talk about disease management. So when I mentioned that we would learn about what do all of these letters and numbers mean, all of these abbreviations and acronyms. So here's kind of a summary of that. For muscle weakness, what are we doing? Physical therapy or PT evaluations. If you've come to our clinic or your local clinic, you've probably done a 6-minute walk test. If you have a little baby, they've probably done the Ames test. It's all these different standardized measures. And it's just a way to get a baseline. How are you performing? How's your child performing? And these are going to be repeated at every single visit, right? Because this condition changes over time. Kids grow and develop, adults grow and develop. So these usually get repeated at every visit and can usually be a lot of hard work. You might undergo pulmonary function testing or PFTs, an echo or EKG, echocardiogram being just an ultrasound or a picture of the heart versus an EKG is just checking the electricity, making sure everything's working okay. You've all probably undergone biomarker testing. We're looking at enzymes like CK, AST, and ALT, which are also enzymes, but they're responsible for completely different things than the GAA enzyme. And so when we see elevations in these, that can usually indicate some kind of muscle damage is happening. That being said, that's just a snapshot in that one moment. So if you have a high CK at one point, doesn't mean it's going to be high the next time. If I were to go run a mile and come back and you were to check my CK, it would be high because that's just muscle breakdown. There's muscle damage that's happening just from normal day-to-day activities. So that's why it's checked at every single visit because we're looking at trends over time. The other lab I wanted to point out are the transaminases or the AST and ALT. These are often called liver enzymes. And they are present in the liver. They're also present in the muscle. So much like GAA, the muscle is what we care about here. So when we see those elevated, it's most likely looking at a problem with the muscle since we know that's the underlying pathology and not with the liver. And so I've talked with a lot of individuals that actually arrived at their Pompe diagnosis because of these high liver function tests. Doctors did all kinds of invasive testing, liver biopsies. They said nothing's wrong with your liver. They eventually found out something else, CK was elevated or something else, and wound up getting a diagnosis. We might check HEX4, which is a urinary biomarker. What that's looking at is essentially, is there glycogen in the urine? Is the most simplified version of that is glycogen getting expelled. We see this as elevated, mostly in IOPD, sometimes in LOPD, depending on disease severity and progression. There's a lot going on this slide, so I won't hit on everything, but my two take home points from here is one, this is a multi-system condition. We're not just looking at the muscles, we're looking at a lot of different parts of the body. A holistic approach to care is really important. Going through the medical system is really challenging. It can lead to depression, anxiety, medical trauma, PTSD. So sometimes children, for example, with Pompe, need an IEP or a 504 plan to make sure they're getting everything they need in school. Mental health counseling is often recommended, not just to people with Pompe, but parents of children who undergo all of this stress trying to manage this condition. That's one takeaway. My second takeaway is this is going to look different for everybody. If you're seeing this and go, wow, my doctor's never recommended X, Y, or Z before, it's important to ask them about that. This, just because it's on this slide doesn't mean it's something that you specifically have to have. It's, like I said, different for everybody in their journey. But this is kind of just a summary of, from my experience in our clinic here at Duke, and also just from the literature, what's recommended. So always talk to your doctor about what's best for you specifically. And with that, I think I've got about 10 minutes or so for Q&A. Um, so I will open up the chat here, I think. Let me stop sharing and see how that, or the Q&A box, right, Tiffany, is where I'm supposed to be.
Yeah, the Q&A, you've got a lot of great questions in there.
All right. Was there any that stuck out to you, or should I just go through them and
There's a little bit of back and forth going on regarding, is Pompe a muscular dystrophy?
hmm. That's a really interesting question, and you'll probably get a different answer depending on who you ask. So it is classified as a type of muscular dystrophy by the MDA, the Muscular Dystrophy Association. But the underlying pathology of Pompe disease is a little bit different than the pathology of, say, like Duchenne muscular dystrophy or like Becker muscular dystrophy. So for the purposes of things like applying for disability or for filling out forms, oftentimes that's like an option that's given that best fits with the symptoms of Pompe disease. And so a lot of people ask that, like, well, does it count as a muscular dystrophy? It is classified as such by the MDA, but like I said, the underlying pathology is actually a little bit different.
Mhm,
So it really just I guess depends on what your purposes are, and probably will also depend who you're asking, a neurologist or
yeah.
geneticist or or me. Um,
Okay. Another one was, are you able to discern genetically if someone with LOPD will present symptomatically early or late in life? If not, is there a way to predict? And then are there subtypes of Pompe genetics that would predict when they will become symptomatic and maybe direct which treatment option might be better?
those are really, really great questions. So just to summarize, it sounds like somebody's asking, is there a way to predict disease severity and symptom onset?
Hmm.
And the answer right now is unfortunately not really. Even we found that individuals, even in the same family, even with the same set of
Hmm.
mutations, don't always present exactly the same. Um, and so, really the best I can do or we can do as the field is look at the mutations and the enzyme and say this is infantile or this is late onset. But exactly how rapidly it'll progress or which body systems will be most affected is highly variable. And so the best thing to do is to just continue regular follow-up. So if you're somebody with LOPD and you've been told, oh, you might not have symptoms or your child might not have symptoms right now, they might develop them later. Um, that's very frustrating, right? Because you're just like, what do I sit around
Hmm.
and wait for something to happen? Um, and that's why I think clinical monitoring routinely, getting on a good schedule is really important, and not being afraid to reach out to your providers to say, hey, this thing is going on. Is that normal? Is that weird? Um, because ultimately your body
Hmm.
the best. And I wish there was a better way. One thing I can say that we've been doing here at Duke for about 5 years, 6 years, I would say now, is following children with LOPD that were picked up on newborn screen to see can we predict
Hmm.
when symptom onset is going to be. And I know I've talked actually for the AMDA before about that exact topic, and it's just unfortunately really difficult to predict. But there's ongoing research. We're working on new ways to do this. So stay tuned for a lot of really cool technologies, I think, coming out in the near future that can help with that.
Yeah, and I think the important thing with the follow-up is also in talking to Dr. Kishnani, making sure it's someone that is well versed in Pompe, because I know in conversations with her that y'all are finding that there are very early signs of disease onset that might go missed in an LOPD patient diagnosed at birth.
Yeah. Yeah, I think, it's always so interesting talking with adults with LOPD that, they weren't diagnosed until they were 50 or 60 or
Mhm.
70. I know somebody that was diagnosed in their 70s. That doesn't mean that individual didn't have symptoms until he was
Mhm.
70. Um, there's also this really unique challenge. This is not, I say it's unique. It's not unique to Pompe, but just there's a lot of variability in kids in
Mhm.
general. You can have two children without Pompe disease that walk at different times, that talk at different times, that have different strengths and weaknesses. And that's just normal variation among humans. And so you
Mhm.
kind of have to take that into account as well.
Mhm.
But then that also leaves with this difficult question of, is this normal kid stuff or is this Pompe disease? And that's been something we've talked with a lot of parents about that really struggle with that. Um, and that's why, again, my kind of always piece of advice is always talk to your provider. No stupid questions.
Yeah.
Always ask, say, is this normal? You know yourself, you know your child the best. And then I know some parents that have, kids where they have multiple children. One of them has Pompe
Mhm.
disease, and they walked the earliest out of everybody, out of
Mhm.
all of their children. Is like, how do you explain that? I don't really know. Um, and so that's why it's most important to, again, when you have, like I mentioned, having that long-term follow-up, that clinical monitoring with the same provider, with somebody who knows you really well. That's always really great if you're able to get established with a clinic like that.
Yeah, I think those are all really good points. Not everything is Pompeii, but you have to be very sensitive to very small changes.
Mhm.
Um, so another question, in OPD, is a 14% GAA function serious? And can your GAA function change over time? Does it
Mm.
go down?
That's a great question. Um, so if we're thinking about GAA, there's a couple of different places we can test how much GAA is in a given body tissue at a given point in time. Most of the time, we're checking blood, your blood cells. You can also test GAA in skin, like fibroblasts, if you've had a skin biopsy, or in muscle cells, if you've had a muscle biopsy. Skin and muscle biopsies aren't super common anymore. Sometimes they're done for like if you're undergoing a surgery or if there's like a really interesting, diagnostic odyssey going on. But somebody with Pompe disease is always going to have deficient GAA no matter what. No matter how old they get, it's never going to go back to the normal range. But that being said, because it naturally can fluctuate, time of day, person, age, whatever, that looking at a number 14%, that's not going to tell me a whole lot about the person and their Pompe disease. Predicting severity is going to be looking at those gene mutations and at the individual themselves. What are we actually dealing with here?
Mhm.
And so that's why I try and encourage people not to get so hung up on the numbers.
Mhm.
We're not really able to assign, much meaning to just a single value at a single point in time. Um, Additionally, if you're just looking at blood, like if we're just talking about blood, I can't necessarily distinguish between IOPD and LOPD. Even if GAA is low, all I can tell you is that it's low. I couldn't tell you which one is which without additional information.
Will your GA activity change though over time? Will it decrease? Your underlying GAA
Like
activity.
because of symptoms, like I said, it'll fluctuate a little bit. So like it's not something that we routinely check over time. It's not a biomarker of disease. So
Mhm.
you could check it once and it could be 1. You could check it again in a few days and it could be, you know, 2, and the cutoff
Mhm.
being like 3 or 4. But that doesn't change the disease severity. It just fluctuates it, but it won't go back into like it won't ever become in the normal range
Mhm.
without like enzyme replacement therapy, basically. So it's not something we check over and over again. Usually it's a
Mhm.
one and done thing unless there's something funky going on with mutations or something, medically unusual.
If someone has low GAA and HEX4 is showing glycogen, they're symptomatic, but they've only found one mutation. What should happen at that point?
Hmm. So let's see if what was it? If hex 4, like let's say hex 4 is elevated,
They have low GAA
low GAA and only one mutation
and they're symptomatic.
and they're symptomatic. Yeah. Yeah, so there's occasionally, and I'm not saying that's the exact case for this situation, but sometimes there's a case of a recessive genetic disease like Pompe, but only one mutation has been found on exam or on testing. You might say, well, then that person's a carrier, but if you have all of these other signs that suggestive of Pompe, then there's some additional type of genetic testing we can do. Generally, what would happen in that case is we would run some additional genetic tests. So most traditional
Mhm,
GAA gene sequencing, we're reading it letter by letter, right? We're looking at that instruction manual, we're reading letter by letter, anything missing
mhm,
or out of place. But sometimes there can be a deletion or a duplication of the gene that's not picked up via traditional genetic testing methods. There could be something in what's called the non-coding regions of DNA and that could be a whole different topic, a whole different presentation.
mhm,
So there are other genetic tests that are done that can pick up those less common mutations. So it's very possible there is a second mutation there, and it just hasn't been found. So I always encourage those individuals to talk to their doctor about making sure all possible genetic testing has been ordered,
mhm,
um, and really getting an expert look at things like the GAA and the
mhm,
Hex4. Like, could these actually be suggestions of something else going on? So oftentimes an expert input is really helpful, and that's somebody who's seen a
mhm.
lot of these cases before.
Yeah, because they're discovering new mutations all the time, right? And new
Yeah.
technology to find the mutations.
Oh yeah. Yeah, there's very little that we know about gene mutations. It seems like there's a lot.
Mhm,
There's been over 2,000 variants
mhm,
in GAA that have been reported. We only know what a portion of them actually mean. So we're still learning a lot. Sometimes testing parents can be really helpful to see, let's say a child has two mutations and both of them came from the same parent. Well, what does that mean? So there's lots of different things we can do. That's not the end, not the end all be all. It's just do the mutations and that's it. There's a lot
mhm.
more information we can find out if we need to.
Do you need any other tests if your genetic results are positive? So I'm assuming that means you have two mutations that are pathogenic.
If you have two pathogenic mutations, then most likely what will happen is somebody will do confirmatory GAA enzyme testing. And if that's low, that's deficient, then those two things together are consistent typically with the diagnosis of Pompe disease.
Mhm.
But as far as getting a diagnosis goes, those are really the main two things that you need. It looks like we're all set at 1 hour, so maybe if there's one more question, Tiffany, we could get to.
Yeah. Do you want to go through and look and see which one?
Yeah, yeah. Mm.
There's one that was asked twice. Does GAA or does Pompe affect the brain?
Oh, that's a really great question. Um, so we know that glycogen buildup can happen most places of the body. So obviously, like our skeletal muscle, that's where we predominantly see buildup of the glycogen. But there's also a lot of research reports showing accumulation in like like your heart, like circulation, like your veins and arteries and things like that. Other parts of the body we don't really typically
Hmm.
get to, because those aren't really easy to access. So things like the brain, we're not really sure what's going on up there most of the time because it's not an easy place to go look and see is there glycogen
Hmm.
accumulation here. Um, so there's a lot of ongoing research studies right now to see what does glycogen accumulation in the brain actually do. So we know that there can be accumulation, and there are studies like in mice, especially. But as far as what it's actually doing, we don't really have a good understanding of that yet. So if there's anybody interested in that, I would definitely encourage them to seek out. There's a lot of great research studies. Um, I can mostly speak for Duke since that's my home, but there's a lot of
Hmm.
studies, especially in Dr. Kishnani's group, that are looking at this exact question. So that's a really great question. I'm glad that got brought up. That there's still so much that we don't know.
Thank you so much, Erin. And there are a ton of questions that we were not able to get to. We will try to get to them maybe offline as we can. And so let's see. I think with that, thank you so much, Erin, for the wonderful presentation today. Thank you to everybody who joined and participated and submitted questions. And with that, thank you for attending today's AMDA webinar on the ABCs of Pompe disease. that concludes our webinar. Happy New Year to everybody, and thank you for participating.
Thanks so much, Tiffany, and to AMDA for having me, everyone. Happy New Year.
Mhm.